on to the talk by Dr. Tushar Grover. He comes from Vision Eye Center. He's a good friend, excellent refractive surgeon, and he's going to be talking about choosing the right fit in phakic IOLs.
So moving slightly away from KLEX and LASIK for a bit. So I'll talk about phakic IOLs and specifically about choosing the right fit. So essentially, to improve outcomes.
Your slides.
Okay.
Slides, please. Okay.
Okay. So starting out with the strategies that you need to adopt pre-operatively to get the best outcomes, to get the best fit, we know that now we are kind of fixated on these sulcus-based posterior chamber phakic IOLs. We've kind of given up on the other ones because these have been found to give the best outcomes. They are the safest, and the outcomes are essentially reliant on getting the measurements right. Now, the most important measurements here are the anterior chamber depth and the white to white. The anterior chamber depth, it's important to measure it from at least two different instruments. We use the optical biometer and the pentacam, but any two different instruments to give you a good idea, and in case there's any variation, you can verify that. Even the white to white, it's important to do it at least from three different instruments. Another instrument that gives us a good guideline is using the manual measurements from the inverse shine plug image that you get from the pentacam. So this is sort of like a starting point for us to go with the digital caliper. So the value that we get from here is the value that we start with when we are using the digital caliper, and the digital caliper is what is most reliable when you're doing the white to white measurement. And the white to white measurements should be done in the supine position under the operating microscope, and it's important to do it in the mid-gray zone. That's where you'll get the most accurate measurements. What you see on the left is a little too small, whereas what you see on the right is a little too large. And based on these measurements, you can use the conventional manufacturer's nomogram to calculate the ICL size that you would need to order. Now, we have recently started moving beyond these conventional methods. What is becoming more popular is the OCT-based formula, because you're able to look at other parameters. The white to white is only a surrogate measurement of where the phakic IOL is actually resting. And there was a lot of talk about sulcus to sulcus using the ultrasound, but the challenge with that was that those measurements were not very repeatable. So now what's catching on and catching favor is the OCT-based formula, because you're able to look at the other factors that are important, such as the crystalline lens rise, the angle to angle, the lens thickness, even the pupil size in some formulae, which is extremely important to determine the vault that you get eventually. This is the lasso formula where you enter the values from the MS39 and the IOL master, and if you just have the IOL master, you can just use those values also. So, and the advantage again is that you also get the predicted vault, which you don't get with the conventional formulae. So, moving on to the intraop strategies, it's really important to know your phakic IOL really well, because all of these have landmarks which are slightly different. You have the ICL, which has, a notch on the leading right foot plate and the trailing left foot plate. Whereas in the IPCL, you have this notch on the leading left, and you have these openings which are towards the eye pro. So it's really important to know your landmarks really well. The IPCL or most of these Indian phakic IOLs are very easy to load, whereas the ICL has a bit of a learning curve where you need to sort of bring the ICL into the hub of the cartridge, and it's important to kind of pull the cartridge away rather than pull the ICL with the forceps. When you're injecting as well, some things are important. It's important not to do a wound-assisted injection in these cases. It's important to be in the anterior chamber when you're injecting, and it's important to point towards the opposite, the periphery, not towards the posterior pole when you're injecting a phakic IOL. And when you're tucking the haptics, it's important to engage on the haptic footplate junction rather than the optic haptic junction, because that's where the phakic IOL is the most flexible. And of course, a thorough viscoelastic wash is extremely important as well. This was the first IPCL that I had done, and I realized only after I had tucked the haptics that it was inverted. So it had to be explanted. Again, very important for that reason to know your landmarks really well. So this had to be explanted, the backup lens was placed, the case went well, but you can see that pigment dispersion which could have been avoided had I been more careful with the landmarks. Now post-operatively, of course, the thing we talk about the most important thing is the vault, and you always want to get it right. What essentially determines your vault to a great extent is your sizing. If your sizing is wrong, you'll end up with an abnormal vault. And we do know that higher vaults put the individual at a risk of angle closure, at pigment dispersion, glaucoma. Lower vaults, you have the risk of cataracts developing, and if you have a toric phakic IOL, the risk of rotation of the toric phakic IOL as well. So vaults, of course, is the most important thing, but you can have some unusual outcomes, rarely in cases with normal vaults as well, such as this case where there was a Uret Zavalia that developed. This individual did have high IOP on day 1. So, and day 0 high IOP is the single most important risk factor in Uret Zavalia syndrome. So it's, again, just reinforcing that it's very important to do a thorough viscoelastic wash. This is another case which had a slightly unusual outcome. The patient's doing pretty well, but you can see this depigmentation of the iris and some pigment dispersion that developed. Still not very sure what caused it because it's an otherwise normal vault. Moxifloxacin, yeah, so those could be factors. And also, I mean, where the phakic IOL is resting sometimes also makes a difference, but because it's not progressive depigmentation or pigment dispersion, it's something that happened and after that it's been stable. So we are observing this patient and the patient otherwise is doing well. But you can have unusual outcomes despite a good vault. So that's just something that we should know of. So phakic IOLs do very well. A few challenging cases here and a few unusual outcomes don't really tell the right picture. Most patients do extremely well, but accurate measurements are extremely important. And we now have the newer formulae like the lasso formula that I spoke about and other OCT based formulae, which are showing some indication that they are better in terms of the sizing, and the additional advantage is that you can actually predict the vault now with these formulae. It's very important to know your phakic IOL really well so that the implantation is smooth, and vault is the single most important factor but not the only one. Thank you.
Thank you, Dr. Tushar. So what is your take on hydroimplantation? Because we see a lot of people doing that. Do you recommend that? Do you feel that it's better to stick to viscoelastic?
I think it is what works for the individual. I personally have attempted hydroimplantation, but I've not felt very comfortable because you do have occasions where the phakic IOL is sort of trying to open inverted. And when you have that viscoelastic in the eye, you're just a lot more comfortable adjusting your injector. Personally, I'm not very comfortable with hydroimplantation. I prefer doing it under viscoelastic, but it is up to individuals. I've seen some live surgeries also with hydroimplantation, and those individuals seem pretty comfortable with it. So if it works for them, great. Not for me.
Yeah, question from the audience.
I mean, I wait at least a week if you have a high vault because of the residual viscoelastic. Sometimes under the phakic IOL, you can have a falsely high vault to begin with. In a week, you get the picture. And if it's an extremely high vault, I would go ahead and explant it. If it's even up to 1,000 microns and otherwise the AC depth is good, it is not causing any issues, I would still leave it alone.
We get a gonioscopy also done if it's a high vault, and if the angles are open, like Dr. Tushar said, then even up to 1,000, you may not have to explant it in that. Generally, the vault does come down over a period of time in these cases to some extent. But that maximum shift is in the first 2 to 3 weeks. After that, it stays fairly stable.
At least, because initially you might not get the right picture. Yeah. So one of the most important things, immediate rise of IOP is usually viscoelastic that is left behind. So wait it out for, like I said, at least a week to 10 days, and that gives you the real picture. Otherwise, it's important to identify what is causing the IOP rise. Is it anterior chamber shallowing because of a high vault? If it is that, then you have to explant. There is no other option. Other than that, if it's any other cause, like I said, most commonly viscoelastic or possibly steroid response, you have to try and identify that also and take the appropriate action. Correct. Correct. So IL master usually overestimates by about 0.5. So I found the pentacam readings to be a little more concomitant with the digital caliper. Even the op scan that way is quite close to the digital caliper. What I trust most is the digital caliper. The IOL master or any optical biometer usually overestimates the white to white.
I agree, and there's actually a recent article by Morgan Micheletti which showed this, and completely agree about you have to decide how you're measuring, but biometry absolutely overestimates what your white to white and therefore the vault will be, and so I would recommend absolutely not using that. I also agree with viscoelastic. I know I have seen those lovely videos using the hydro insertion, but I don't know, I kind of hear some endothelial cells crying when, you know, when I see that. It just makes me a little sad because I really like endothelial cells and I don't like to hear them cry or scream. So I definitely agree with that. I'm wondering if you're using one of the online formulas now, like ICL Guru, or what's your go-to for formula?
So for actually choosing the size, I'm still going with the OCOS, the conventional formula. But I have retrospectively looked at the lasso formula and analyzed some of the cases. And it's probably more accurate, but there is also a bias because you look at those cases where you had a low vault or a high vault, and then you look at the lasso formula and you feel this might have been better. But maybe when we start using the lasso formula for all cases, we might find those abnormalities or those rare cases where it's off, even in this case. So I'm not sure yet.
I think there's a question.
Thank you for the presentation. One question, you remark that it's essential to have accurate measurements. Anyway, with OCT you are doing angle to angle. This is not the place where you put the ICL. You have the sulcus to sulcus and should be an accurate measure, especially if you take consideration that if you have plateau iris, the collapse of the circ makes the measure different for white to white and also for angle to angle. And right now, I've realized because it's easy to work with OCT, it's very friendly, and the people is a little bit scared about UBM.
Yeah.
But right now, there are some devices that they have the capability to make the automatic measurement with this align. And what is your experience about the UBM? Right now, we know also that Saldivar is doing a formula just to calculate not only the distance, but also the ball of the lens. Please, can you tell us about it?
Some of the very high resolution ultrasounds, there are new formulae coming out, like Dr. Einstein has started talking about the ciliary body inner diameter based on a very high resolution ultrasound. So those work well is what it shows in the studies, but with the conventional ultrasounds, the measurements of sulcus to sulcus and the repeatability of that has been a challenge. So say I measure the sulcus to sulcus and somebody else measures it, there is quite often a variability, and that's what literature has shown as well, which is probably why the other things
I think the technology to make the ultrasound is make the difference.
Yeah.
Because when you use a sectoral UBM,
Yeah.
in the periphery we are getting a cosinus of angle of the reflection of the ultrasound.
Yeah.
But we will use a linear probe. We are getting perpendicular to the places.
Yeah.
And the resolution has increased right
Yeah.
now in some devices.
Yeah, I think that's the way it has to go in the future, because we should be looking at where the phakic IOL actually is. It is in the sulcus. Even angle to angle is a surrogate measurement, just like how white to white is. So eventually we should get to a point where we are able to look at the sulcus, in fact even look at the morphology of the ciliary body, where because in some cases the way that the haptics of the phakic IOL rest is quite different. So again, the ideal way is to go about and reach a point where we're able to actually look at that and measure that area and analyze the morphology of that area to get the perfect vault. We'll still be lacking till we are using any surrogate measurement.
Thank you.
I think we'll have to move ahead. We're running short of time.
So I just use the regular dispersive viscoelastic. I don't feel the need to, HPMC is what I use.
We'll take questions at the end because I think we're